Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Dr. Anne Vriese in Bruges, Belgium, with whom we would like to discuss anticoagulation in chronic kidney disease, CKD patients with atrial fibrillation. Anne, we are very happy to have you tonight as our expert.
Thank you very much for having me. I'm very excited to have this discussion with you.
Dr. de Vries is head of the Department of Nephrology and Infectious Diseases at St. Jan Hospital in Bruges, Belgium, and she's professor of nephrology at the University of Ghent. She's a leading international expert in at least two quite different fields of nephrology. So the first one would be glomerulonephritis, the second one surely cardiorenal disease. And to our best understanding, she's the only investigator globally so far who has initiated, conducted, finalized, and reported a randomized controlled trial on anticoagulation in dialysis patients, the VALKYRIE trial. Others have started some trials, but they are not yet reported. My co-moderators tonight are Professor Stephan Schirmer, who's cardiologist at Kaiserslautern, Dr. Marlies Antlanger, who's nephrologist in Linz, Austria, and who also did academic work in the field of atrial fibrillation in CKD patients. My name is Gunnar Heine. I'm a nephrologist in Frankfurt, Germany. So, Anne, before switching the microphone to Marlies, I would kindly ask you to give us some first comments on the challenge of anticoagulation of patients with chronic kidney disease who have atrial fibrillation. So why is it important to discuss this topic?
Well, the way I see it, the main challenge of anticoagulation management for atrial fibrillation in patients with CKD is that we cannot extrapolate the results that have been obtained in the general population to the CKD population, since, as you know, it has many particularities that profoundly alter the risk-benefit ratio of treatment in general and of anticoagulation in particular. And as you know, patients with chronic kidney disease, and especially those on dialysis, they have been almost universally excluded from the major trials. And very few studies have been performed in CKD, and in particular in the dialysis population per se. So as you discussed, we have conducted the VALKYRIE trial, a small trial, nevertheless took a lot of effort. Still the only randomized controlled trial with published results in the dialysis population. So unfortunately, what we will be discussing today is to a large extent based on interpretation and opinion. And I've always found it ironic that we routinely treat patients with CKD and atrial fibrillation every day with great uncertainty as to benefit or harm without their consent, while at the same time there's major regulatory and ethical barriers that prevent the official enrollment and recruitment of patients into these clinical trials that are essential to take away this uncertainty. So that's why we were very motivated to set up the VALKYRIE trial.
Well, thank you very much for this introduction, and it's truly a pleasure and honor to meet you today. So my first question circles around the overall question of anticoagulation in our patients. And we have the CHA2DS2-VASc risk score, which is a pretty well-validated tool for the prediction of stroke risk in patients with non-valvular atrial fibrillation. And in the overall population, correct treatment, according to this score, lowers the risk of stroke by approximately 2/3. However, this score has only been validated for low-risk patients, which by itself excludes patients with advanced CKD. So my first question is, where does this evidence end? Should we anticoagulate our patients at all? And at which eGFR is the evidence gone?
Yes, so that's indeed a very fundamental point. Should we give anticoagulation or no anticoagulation to patients with CKD and across the spectrum of CKD, and where is the watershed where the evidence disappears? But before we go any further, maybe we should go into the issue of why do we give anticoagulation at all to a patient with atrial fibrillation? The intention is obviously to reduce the risk of stroke and systemic embolism. But the decision to use anticoagulation also involves weighing the risk of a thromboembolic event without therapy against the risk of a hemorrhagic event on therapy. Now, this is a broad generalization that doesn't help us any forward, so we may have to break it down into manageable chunks and ask us, first of all, what is the relationship between atrial fibrillation and stroke? Is atrial fibrillation an effector of stroke? And is that relationship between atrial fibrillation and stroke altered in CKD and in particular in hemodialysis? So we know that atrial fibrillation is initially paroxysmal, trigger-driven, and it progresses to a persistent and ultimately a permanent form when there's structural atrial remodeling. The importance of paroxysmal atrial fibrillation should not be underestimated, since studies have suggested that this form is associated with the greatest risk of stroke, although other studies then have demonstrated that the risk of stroke is rather directly proportional to the burden of atrial fibrillation. But specifically for the dialysis population, studies with implantable loop recorders have revealed that episodes of occult atrial fibrillation are very common, and they cluster around the dialysis session itself as a result of the fluid and electrolyte shifts. So when a bout of atrial fibrillation occurs when the patient is already hypernized, I'm inclined to think that the risk of a thromboembolic complication is low. And indeed, there was an epidemiological study that demonstrated that there was an increased risk of stroke in hemodialysis patients with a permanent form of atrial fibrillation as compared to hemodialysis patients without a permanent form of atrial fibrillation. So this is already very different from the situation in the general population, where atrial fibrillation of different patterns are treated similarly with respect to anticoagulation indication. But even permanent atrial fibrillation may not be as an important effector of stroke in patients with CKD, because they may have more thrombotic stroke than embolic stroke. And we know that, as you mentioned, stroke risk is determined by the individual patient risk profile that is reflected in the CHEST-VASc score. But there was this very intriguing study in American Journal of Cardiology, I believe, a couple of years ago, showing that the CHEST-VASc score also predicts ischemic stroke in patients without atrial fibrillation. And this suggests that the cardiovascular risk factors that are included in the CHEST-VASc score are in and of themselves intrinsically prothrombotic. So what I mean is that the relationship between atrial fibrillation and stroke is not as straightforward in CKD, and in particular in the hemodialysis population, as it is in the general population. And so the second consideration that we should make when we decide whether or not to give anticoagulation is how is the risk-benefit ratio of anticoagulation? Is it favorable? Because as kidney function declines, the risk of stroke obviously increases, but the risk of bleeding also increases. So the risk-benefit ratio may change as we move across the spectrum of CKD. So, as you've said, across the spectrum, the evidence is becoming more scanty. So there is some evidence in CKD stage 3. But for CKD stage 4, the evidence is more scanty and is mainly based on observational studies. And there was this, I believe, systematic review published in American Journal of Kidney Disease in 2021, I believe. The first author was Sue, revealing that in stage CKD 4, oral anticoagulation reduced the risk of thromboembolic complications, reduced the risk of death, but caused more bleeding events. And this was also true for dialysis patients. Now, we have performed our own meta-analysis in dialysis patients exclusively in patients on hemodialysis. We were able to separate peritoneal dialysis and patients with CKD stage 4 from the trials, and we reached similar conclusions. So no reduction in the risk of thromboembolic events, no reduction in the risk of mortality, and increased bleeding events. But we had to make two disclaimers. We noticed that a substantial proportion of patients that were included in the original studies were low risk. They had CHA2DS2-VASc scores below 2. And of course, in that population, you cannot expect a good benefit ratio, risk-benefit ratio of oral anticoagulants. And secondly, what we noticed is that the quality of anticoagulation was very poor. So we believe that if you can provide more on-target anticoagulation in dialysis patients and give it to high-risk dialysis patients only, you may reach different conclusions. But obviously, if you ultimately want this question to be answered, you need randomized controlled trials comparing oral anticoagulation versus no anticoagulation. And so far, these have not been published in CKD4 and in CKD5 and in dialysis. I believe there's 2 randomized controlled trials that are currently recruiting. There's one Danish trial, the Denver trial, and one French trial, AVK-DIAL, that target to recruit 700, 800 patients. But so far, I have not heard any conclusions from this trial. So unfortunately, we only have data from observational studies in the populations that interest us most.
So the issue is much more complicated than it might appear at first sight. And you already mentioned the issue of risk stratification in this population, because the CHA2DS2-VASc score seems to be a bit problematic because almost every single patient on dialysis would require to get an oral anticoagulation treatment once they have atrial fibrillation. And I just looked up the last KDIGO controversies conference on the issue of atrial fibrillation. That was from 2016. And they stated, I quote, the predictive value of stroke risk scores, including CHA2DS2-VAScs in CKD G5, is similar to that in the general population. And I'm not sure if I would agree to that statement, but it's been a couple of years. But what would you consider to be important factors and comorbidities in dialysis patients? And what do you think a good and applicable risk score would include?
Well, I also do not agree with that statement because the components of the CHA2DS2-VASc score, that is congestive heart failure, hypertension, advanced age, diabetes, a history of stroke, vascular disease, they are so prevalent in dialysis patients with atrial fibrillation that, as you said, most would qualify for oral anticoagulation if you extrapolate the guidelines from the general population. I think more than 95% of dialysis patients have a CHA2DS2-VASc score of 2 or greater. There's one study that found that 50% of patients on dialysis had a CHA2DS2-VASc score of 5 to 9. And in our own VALKYRIE trial, the median CHA2DS2-VASc score was 5. So, and it's true that several studies have found that as the CHA2DS2-VASc score increases in dialysis patients, the risk of stroke also increases. But if you compare dialysis patients and non-dialysis patients that have the same CHA2DS2-VASc score, then the incidence of stroke is lower in dialysis patients, implying that the CHA2DS2-VASc score overestimates the stroke risk in dialysis patients. And in our opinion, the current application of the CHA2DS2-VASc score does not adequately discriminate between dialysis patients that would derive a net benefit and those that would suffer a net harm from anticoagulation. But true, what should we do then? It's not very clear. Perhaps we should set the threshold for anticoagulation higher than 2, for instance 5. We should maybe alter the weight of certain components in the CHEST-VASc score. For instance, give more weight to history of stroke, because that has clearly been demonstrated to be a very strong predictor of subsequent stroke in dialysis patients. Or maybe we should take into account more dialysis-specific risk factors. Or, as we mentioned, maybe we should take into account the pattern of atrial fibrillation and not give weight to a paroxysmal form of atrial fibrillation, in particular when it's occurring only during the dialysis sessions. In addition, maybe we should incorporate bleeding risk in the same risk stroke. And if we do that, how should we do it? Because we know that none of the bleeding scores that are available for the general population are of value in advanced CKD. So we in our center, but this is purely opinion-based, we have a homemade dialysis risk score, as we call it. And we have developed this based on the study from Vriese that was published a long time ago that showed that 3 of the components of the CHEST-VASc score, that is history of stroke, diabetes, and older age, are significantly associated with subsequent stroke, while the other 2, hypertension and heart failure, are not. So we, in our dialysis risk score, we give most weight to history of stroke. We give 3 points. We give 1 point to age, we give 1 point to diabetes, and then we subtract 1 point for gastrointestinal bleeding in the previous 12 months, since there's also quite some evidence, also from our VALKYRIE trial, that this is the best predictor of subsequent bleeding. And so only when a patient has our own dialysis risk score of 2 or greater, we give anticoagulation. And those that have a dialysis risk score of smaller than 2, we do not give anticoagulation. And if we look at our results, we only currently anticoagulate about 40% would qualify for anticoagulation based on the official guidelines. We certainly see less major bleeding, obviously, but we do not appear to see more ischemic strokes. So. But unfortunately, we have not officially validated this score.
You also mentioned a lack of evidence and many observational studies. So, I mean, there are many patients actually with CKD and or on dialysis that have or suffer from atrial fibrillation, but I also hardly found any studies. And the VALKYRIE study certainly was one of the first ones that was really conducted as a randomized controlled trial on this issue. And I think Professor Schirmer is going to do a deep dive on these data, obviously. My question would be, where do you still see a lack of studies? What still needs to be studied in the dialysis population and also in the CKD population? We always think of the extremes with dialysis patients, but do we forget about CKD4 patients or CKD5 who are not on dialysis? Do we need to answer questions like, should we actively stop oral anticoagulation once a patient transitions to dialysis, etc.?
Yes, well, what you mentioned is that we only have observational studies in CKD4 and CKD5. The VALKYRIE trial is the only randomized control trial, but it's a small trial and it is mainly serves as a kind of to inform the design of larger trials, I believe, because the observational studies are really problematic. There's a very important confounding by indication. You have the patients that are at the highest risk of stroke. They are more likely to be anticoagulated by the treating physician. So patients that are receiving anticoagulation appear then to have a higher stroke risk. Conversely, patients that are supporting anticoagulation long-term, they may be healthier than those who have to discontinue anticoagulation, for instance, due to a bleeding episode. So then if you find in an observational study a lower mortality in those on anticoagulation, is it due to the anticoagulation or is it due to the fact that they are healthier in the first place? So many studies have tried to account for this by controlling for risk factors, etc., for propensity score adjustments, but this is unlikely going to remove all possible confounders. because as you know, in all these databases, there's poor record keeping, and also the simple prevalence of a risk factor like diabetes, but not its severity, duration, treatment. This will not give you adequate predictive information. So even with careful adjustment, these observational studies, they are limited by unmeasured confounding, by selection bias, and the conclusions are unreliable. So I really believe that we should move away from more observational studies and design randomized controlled trials where we compare anticoagulation treatment with placebo. But with which type of anticoagulation then we can discuss further on. But but before we do that, we must decide on which risk stratification tool we will use in the dialysis population. I think this is a very important issue that should be addressed first of all.
And my last question centers around the elder care study, which was a pretty interesting trial published in 2020, where Japanese patients that were at least 80 years old were subjected to a highly reduced dose of edoxaban versus placebo. And they showed a hazard ratio of 0.34 for stroke, while the bleeding risk only increased insignificantly. Do you think we should go for a similar compromise in CKD patients? And I mean, the population was not that much different from dialysis patients. These patients were all assessed and felt to be very frail. They were measured as to be very frail. They had highly reduced GFR, etc.
Yes, as you mentioned, so the patients that were included, in fact, they're very similar to our dialysis population or our CKD5 population. We were very old. I believe that the mean age in elder care was like 87 years old. And they were all considered to be inappropriate candidates for DOAC at regular doses because they had either a low creatinine clearance or they had a history of serious bleeding. They had a low body weight. They used, I think it was like 50% antiplatelet drugs. They had a lot of use of non-steroidal drugs. So a very old, very frail population at a high risk of gastrointestinal bleeding, very similar to our dialysis population. And what they found is that the low dose edoxaban, 15 milligrams, as compared to placebo, as you mentioned, significantly reduced the risk of stroke. There was a non-significant increase in major bleeding, but importantly, the risk of intracranial hemorrhage was not increased. The risk of gastrointestinal bleeding was tripled, but what can you expect in such a patient population at high risk of gastrointestinal bleeding? So that was not a very unexpected finding. But indeed, I think it could serve as a model for the design of trials in the dialysis population, where we aim for doses of DOAC at the lower end of the spectrum. Because we cannot forget that we also give low molecular weight heparins in dialysis patients. And there's no means to measure the additive effect in the laboratory of low molecular weight heparins and DOAC, because they are different kits. You may measure anti-10A activity for low molecular weight heparins or for DOAC, but you cannot combine both tests in a single kit. But of course, in vivo, you will have an additive effect of the low molecular weight heparins that we administer during dialysis and the DOAC that the patient is receiving. So I think we have to aim for DOAC doses at the lower end of the spectrum. And we can learn from elder care in that respect.
Before discussing vitamin K antagonists and DOACs, I would just briefly like to know from each of you, do you use this 50 milligrams from time to time? Because we in Frankfurt actually do. I'm aware this is not licensed in Germany, neither in Austria and Belgium, I guess. But do you use this dosage sometimes?
Well, if we go further and discuss the DOAC, I will give you my opinion on which DOAC we prefer to use, because I believe that apixaban has many advantages in the CKD population. So we are inclined to switch to apixaban once we see that kidney function is declining.
I have one more question about the things you said. And I'd also like to sort of challenge or discuss one issue. You said the dialysis patient often has electrolyte changes and that you observe atrial fibrillation if it's paroxysmal during dialysis and the patient is anticoagulated during this time anyway. On the other hand, and you said that already, we have quite a good bit of evidence that paroxysmal permanent AF might correlate to stroke severity or stroke or might not. At the same time, we have some evidence from patients with implanted recorders or pacemakers that stroke doesn't actually happen during AF, and that AF is just a symptom of a not healthy atrium and not healthy heart, and that these patients are prone to stroke or embolic stroke. So this wouldn't help then, would it? I mean, patient might just as well get a stroke on day 2 after dialysis when he or she is not anticoagulated and is not in AF.
So what you're saying is that even that the stroke is that we are not going to prevent stroke with any form of anticoagulation in dialysis patients. I do believe that some of the strokes in dialysis patients will be embolic, and that it's.
I agree. I meant that with anticoagulation only during dialysis, which is happening every now and then. Quite a few nephrologists and also other doctors say, okay, we're heparinized 3-4 times a week, and that's enough. But obviously, even if AF occurs only during that time, he or she might still get a stroke, embolic stroke, on the days in between.
Yes, but if the atrial fibrillation only occurs at the moment when the patient is already anticoagulated, maybe there will not form a clot in the atrium that can at a later time embolize. So, well, this is just hypothesis. Who knows? There's very few studies that have done, for obvious reasons, because the implantable loop recorders are very expensive. But what we really need is studies that look at the pattern of atrial fibrillation in dialysis patients and try to correlate this with stroke risk.
Very, very important issue. Thank you for your insights. What we'd like to switch to is really your thoughts, and you already alluded to on if we do anticoagulate, and we heard from you already about your thoughts a little bit, which group of anticoagulant do we use? Is there any role, to put it more provocative, for VKA in CKD 3-4 or dialysis? Yes,
well, in the general population with atrial fibrillation, DOAC are now increasingly used for the prevention of stroke and systemic embolism because in comparison with vitamin K antagonists, they're either superior or non-inferior with respect to thrombal prophylaxis, or they have a better safety profile, with in particular lower intracranial hemorrhage. That's consistent throughout the studies, trend to less major bleeding, in particular with apixaban. And it's mainly this better safety profile that has been the driver to change the atrial fibrillation guidelines and that recommend now DOAC over vitamin K antagonists in the general population. For CKD3, there's indeed then some evidence from the subpopulation of patients that were included in the original randomized controlled trials that is strong, and there's a couple of meta-analysis and one Cochrane review. They were not entirely concordant, but the overall conclusion was that the efficacy and the safety of the DOAC compared to warfarin is similar in CKD3 than in the general population. So for that subpopulation, we have, I think, solid evidence. And then for CKD4, since, as you know, patients with creatinine clearance below 30 for rivaroxaban and dabigatran and creatinine clearance below 25 for apixaban were excluded from the randomized controlled trials, we have no high quality data. We have only observational studies. And in those observational studies, no major safety signals with respect to DOAC were detected. So, well, we cannot officially conclude that DOAC are better than warfarin in CKD4, but it looks like the bulk of evidence suggests that it does. There's also data beyond from prophylaxis and bleeding in CKD4. There's one large observational study from Canada showing that each DOAC was associated with a lower risk of acute kidney injury as compared to warfarin, and in particular when compared to warfarin users with a low time in the therapeutic range. And among patients with eGFR below 30, the group that has the highest risk of acute kidney injury, apixaban was apparently associated with a 50% reduction in the risk of acute kidney injury as compared to warfarin. So I believe that the bulk of evidence, although not high quality, suggests that DOAC are also the preferred treatment in CKD4. And then in dialysis, of course, it's very problematic. There's only a few observational studies. Generally, there were fewer bleeding events with DOAC than with warfarin, except in this study by Chen, published in Circulation in 2015, that, in my view, is too frequently cited because there were major flaws in the study. Bleeding occurred more frequently with dabigatran and rivaroxaban than with vitamin K antagonists, but the DOAC doses were inappropriately high for the degree of renal failure. A large proportion of patients in dialysis used dabigatran and rivaroxaban at the full dose. So then it's not a surprise to find an increased bleeding risk. So I believe that that study is flawed by the inappropriate dosing regimens, and it should not be cited as evidence against DOAC in dialysis. So, and then of course, you have the randomized controlled trials. There are several that are ongoing. So far, the only one that is published is our own VALKYRIE study, a collaborative effort of 3 large dialysis centers in Flanders. We originally designed it to assess the effect of vitamin K status on vascular calcification endpoints because we wanted to compare the extremes of vitamin K status. Patients were randomized to either vitamin K antagonists with an INR target of 2 to 3, and then we expected vitamin K status to be at its lowest, or rivaroxaban 10 milligrams with a high dose vitamin K2 supplement, and in that treatment arm, we expected vitamin K status to be at its best. And then we had an intermediary group with rivaroxaban 10 milligrams daily only, in order to separate the effect of the vitamin K antagonist replacement by rivaroxaban from the effect of the vitamin K supplements. And this 10 milligram dose of rivaroxaban, we based it on a pharmacokinetic study that we performed ourselves, where we demonstrated in hemodialysis patients that 10 milligrams of rivaroxaban is the equivalent of 20 milligram in healthy volunteers. So we did this for 18 months, and then we were very disappointed to see that there was no significant difference in vascular calcification progression, but we did find a borderline significant difference in major bleeding complications at the advantage of rivaroxaban. And so patients that completed the VALKYRIE study, they continued the originally assigned treatment, and we extended the follow-up for an additional 18 months, at least 18 months. So we achieved an overall median follow-up, I guess, of nearly 2 years. And then we found that the primary efficacy endpoint, that was a composite of fatal and non-fatal cardiovascular events, was significantly higher in the vitamin K antagonist group as compared to both rivaroxaban groups. Also, life-threatening bleeding, major bleeding that we adjusted for competing risk of death occurred much more frequently with the vitamin K antagonist than with rivaroxaban. So overall, there was a clear net clinical benefit for rivaroxaban versus vitamin K antagonists. And the fact that we were able to demonstrate this in a small trial of only 132 patients suggests that it is of major clinical relevance. So I believe, but this is belief, that we can extend the findings from the general population on the superiority of DOACs versus warfarin I think we can extend this to the population with CKD all the way up to dialysis.
The fact that you have less bleeding and less cardiovascular events that mightn't necessarily be ischemic stroke, is it the old rule that whenever you have bleeding, we stop all the other drugs and then people get events, cardiovascular ischemic events? Or why is the DOAC superior on both sides of the biological spectrum, really?
Yes, that's indeed an important point. So how can you reconcile the fact that you have a better protection against stroke and at the same time have less bleeding? Because if it's just an anticoagulant effect, then they would not go both in the same direction. So I believe there's two potential explanations. First, it's the intensity of anticoagulation. We know that the intensity of anticoagulation is the most important predictor of the effectiveness of vitamin K antagonists. And you need a time in the therapeutic range of at least 70% to have a significantly reduced risk of stroke. Now, patients with CKD, they never achieve this. The further you go across the spectrum of CKD, the worse your time in the therapeutic range. And in patients on hemodialysis, it's usually around 50% because of multiple factors, interference in the vitamin K antagonist metabolism by uremia, because of drug interactions, because of frequent interruptions of the vitamin K antagonists for diagnostic procedures, as we all know, in dialysis patients, subclinical vitamin K deficiency. There's a number of reasons why that is the case. And it doesn't appear that we can improve this. There's one study that administered it twice weekly after dialysis to a certain adherence, but it only marginally improved time in the therapeutic range from, I think, 50% to 55% something. So in dialysis patients, it's nearly impossible to have a good time in the therapeutic range. And it has been clearly demonstrated that bleeding complications occur when the INR is supratherapeutic, and that the thrombotic complications occur when the INR is subtherapeutic. So on the other hand, DOAC, they may have more consistent, more predictable anticoagulation, more on-target anticoagulation, and that may lead to a better protection against stroke and major bleeding. In the VALKYRIE study, we found that there were significantly less life-threatening and major bleeding complications with rivaroxaban, but the total number of bleeding episodes was not reduced. So I like to believe that rivaroxaban caused a shift in bleeding severity from severe to less severe by providing more stable, more on-target anticoagulation than the vitamin K antagonists. So that might explain already part of the difference between the vitamin K antagonists and the DOAC. And I think the second important point is off-target effects. The high risk of intracranial hemorrhage that you see with vitamin K antagonists, originally it was attributed to impaired coagulation. But why do the DOAC have a 50% lower risk of intracranial hemorrhage, even though they give as much or even more gastrointestinal bleeding? So this has probably to do with the off-target effects of the vitamin K antagonists. They inhibit vitamin K-dependent proteins, as you know, the matrix GLA protein, that apparently is essential for angiogenesis, because we see that matrix GLA protein knockout mice, they have an abnormal angiogenesis, they have a more fragile vasculature, and they have an increased risk of intracranial bleeding. So this intracranial bleeding is something that is specific to the vitamin K antagonists, and that has to do with the off-target effects. And then finally, there's the issue of the vascular calcifications that are also the consequence of the inhibition of the vitamin K-dependent protein, matrix GLA protein. So we know that the vitamin K antagonists have the tendency to be procalcific, and DOAC do not interfere with vitamin K-dependent proteins, so they are not expected to have these effects. Even better, there has been a couple of animal experimental studies that demonstrate that DOAC may have some intrinsic direct protective effects on the vasculature. Although honesty commands me to say that some studies are also negative.
Now, before asking you to give us your thoughts on maybe the best NOAC or DOAC, and you already shared some of the thoughts, do we have to use a substance that is very little cleared by the kidneys, or couldn't we just give something like the dabigatran just after dialysis, keep it in plasma until the next dialysis because it's cleared via dialysis? And just one single pill, and it's not going to be cleared by the kidneys because they don't work anymore. Wouldn't that work?
The dabigatran is 80% renally eliminated, and a 4-hour hemodialysis session removes about 50 to 60%. So there's a risk of accumulation on the one hand, and then I think the effect of dialysis may be unpredictable because, as you know, dialysis patients, sometimes they miss a dialysis session, or the dialysis session is prolonged or shortened or whatever. So I would rule out the dabigatran as a candidate in hemodialysis. I would think that is too dangerous and too unpredictable.
So before Stephan comes back to the question of the best DOAC in CKD, I have 2 or 3 more comments or questions on VALKYRIE. So firstly, you said you were somewhat disappointed that the first analysis on calcification were negative. But if you look at your publication, I think there's a very strong tendency actually that already shows that it's not really good to have warfarin if you are on dialysis, because the curves actually start to diverge after a few months only.
Yes, I have received that comment several times, that in the coronary arteries, there's a trend that warfarin does worse than the other 2 groups. But at the time when we had designed VALKYRIE, we were still, we didn't think as much of the DOAC as protective. We thought of the vitamin K status as being essential. And so we thought, if this is really a true phenomenon and not some statistical issue, but if this is a real effect that we see, and it's related to the inhibition of vitamin K, then we would need to see a protection of the supplements of vitamin K, because the matrix glyprotein levels, the inactive matrix glyprotein levels that we measured as a surrogate marker of vitamin K status, they separated very nicely in the 3 groups. So the 3 groups had very different vitamin K status. So if vitamin K was essential for the observed effects, then we would have to see a separation in between the rivaroxaban only and the rivaroxaban and the high dose vitamin K, and we didn't see that at all. It was not even a trend, there was nothing there. So, but now that I've learned about potential protective effects of DOAC on the vasculature, I tend to believe that it is actually the rivaroxaban that is being protective and the vitamin K antagonist that is being harmful. And that might explain the separation of the curves that we saw there.
1/3 of all study participants were on aspirin. And since we saw so many bleedings in both arms, much more severe bleeding with warfarin, but also in the rivaroxaban group, tremendously high number. So if you would be able to redo the study, would you exclude patients who are on aspirin or other antithrombotic agents?
Yes, that's something that we've also learned by experience. There's very few data about that, how you manage patients that qualify for antiplatelet agents because they have had an event in the past, and that also qualify for oral anticoagulation. That's a very difficult issue, and I don't think anybody has a very good answer for that. What we do is we tend to look very carefully now at indications for both. If the event that has given rise to the prescription of the antiplatelet agent, if it's in the past and there's no recent events then we tend to drop the antiplatelet agent and only go for the oral anticoagulant. On the other hand, if we do not have a dialysis risk score that is high enough, then we tend to drop the oral anticoagulant and only give the antiplatelet agent. So I agree with you that we should avoid in dialysis patients to combine both and only do that in patients that have a very strong indication for oral anticoagulation on the one hand, and that have a recent vascular event that requires treatment with antiplatelet agents on the other hand.
And my last question on VALKYRIE before Stephan re-ask you the question about the best DOAC. So why is it VALKYRIE? Why did you decide to name this study VALKYRIE? We see so many nice names in nephrology with Figaro and with Fidelio. Why did you go with VALKYRIE?
Well, VALKYRIE, it contains a V, a K, and an R, but it's not an acronym. And I was also not inspired by the movie with Tom Cruise, who played General from Stauffenberg and wanted to use Operation VALKYRIE against the Nazis. So I just like the Valkyries, the goddesses of the Nordic mythology. You know that the Valkyries, they apportion victory in battle and they score the battlefields for those warriors who are particularly brave or have shown particular skill in the arts of combat. And when such warriors die, then the Valkyries carry them to Valhalla. So I really like those, and that's why we call it like that.
Repetition, and you already said that basically. Maybe you can give us your reason why you think apixaban is actually the best drug to use, at least in dialysis.
Well, there's a recent systematic review and pairwise network meta-analysis that was published in the American Journal of Kidney Disease was very helpful in this respect. Different DOACs in patients with atrial fibrillation with CKD stage 3 to 5D from observational studies. There were 4 direct comparisons. They did not find any significant differences between DOACs in terms of bleeding and thromboembolic events. But a network meta-analysis for indirect comparisons between different DOACs found that dose-adjusted apixaban and edoxaban 15 milligrams were superior to the other DOAC regimens in terms of reducing bleeding complications, but dose-adjusted apixaban was more effective than edoxaban in preventing thromboembolic events. So the best trade-off between protection against thromboembolism and not causing bleeding is seen with dose-adjusted apixaban. And just other studies also showing that the risk reduction in major bleeding with apixaban versus vitamin K antagonists increases as renal function decreases. So I believe that apixaban appears to be a good choice across the entire spectrum of kidney function because of its predominant non-renal elimination.
And from a practical point of view, would you pause the dose or at least leave out one dose on the day of dialysis?
No, we don't do that. We don't do that. No, it's a good point. A good point that you could say that you don't give the morning dose in patients that have a morning dialysis session, but we believe that it's too complicated for patients, for nurses, and it carries a high risk of mistakes. So I believe in simplicity when you give instructions with respect to medication to patients.
That's always very good from a cardiology point of view. We also believe in simplicity, and we discussed this several times. Gunnar, because you asked me, you asked some questions. If you don't mind, I need to ask this now because it's also a cardiology thing. We talked a lot about anticoagulation, but we obviously do have another measure of stroke prevention in atrial fibrillation that's interventionally done by the cardiologist, which is LAA occlusion. We don't want to go into depth of the data here, but just what are your thoughts on that? Because obviously some interventional cardiologists would say we don't need anticoagulants in dialysis patients with AF at all. We just close the LAA and we're done.
Yes. So yes, of course, left atrial appendage closure, it's an attractive option to reduce thromboembolic events in patients that are not good candidates for long-term anticoagulation. And it would be a very attractive option in our patient population. In the general population, it has been shown to be non-inferior to warfarin and to DOAC with respect to efficacy. It's associated with less bleeding. But we have learned that we cannot extrapolate evidence from the general population to CKD, and certainly not to end-stage kidney disease. It was this recent publication, a database study of more than 20,000 patients that underwent left atrial appendage closure. And it revealed that the procedure was indeed associated with significantly more complications, more mortality in patients with CKD, in particular in those on dialysis. So the critical question remains, how does left atrial appendage closure compare with medical therapy, even with placebo in our patients? And we need randomized controlled trials for that. Unfortunately, the Stop Harm trial that was designed to compare the Watchman device with vitamin K antagonists on the one hand, with a rivaroxaban arm, there was an apixaban arm, but it was withdrawn for failure to recruit patients, demonstrating again how difficult it is to perform trials in dialysis patients, unfortunately.
So I have two concluding questions, which are rather practical issues. We have a lot of discussion in Germany when adjusting DOACs to renal function. Should we go for estimated GFR or should we go for creatinine clearance? Surely people tend to use the eGFR because it's easier, it's on the lab sheet. I always try to defend the creatinine clearance because that's actually the way the drugs were tested. What are your ideas on this?
Yes, it's true. As you say, all randomized controlled trials, all pharmacokinetic studies, the FDA recommendations, they all use the Cockcroft-Gold formula to estimate kidney function. But as you say, in clinical practice, we are used to using the CKD EPI, the MDRD formulas, because they are readily available. And we know that both the CKD EPI and the MDRD, they give higher estimates of renal function than the Cockcroft and Gold. There was one study that showed that the number of participants that were estimated to have a creatinine clearance below 50 was about 25% with the CKD EPI and the MDRD, while it was almost 50% with the Cockcroft-Gold. So in other words, as compared to the Cockcroft-Gold, the CKD EPI and the MDRD classified fewer participants as having an impaired kidney function and thus requiring a dose reduction. So what should we do? There has been quite some research on this issue, but in my view, none of the studies asks the right question. The right question is, if we make dose adjustments based on CKD EPI or MDRD versus the official dose adjustments on Cockcroft-Gold, does that lead to better or worse outcomes? And that question has not been appropriately researched, so I cannot give you an official answer. Most authors write about the subject, they make a politically correct statement. They advise to use the Cockcroft-Gold because the randomized controlled trials have used the Cockcroft-Gold. But in clinical practice, do you really think this is going to happen? That general practitioners or cardiologists, I'm sorry, will look up the Cockcroft-Gold formula and then calculate it before they make the dose adjustments. I don't think this is going to happen. So if we use common sense, it is the true kidney function that will determine the serum level of the DOAC. And we know that CKD EPI performs better than MDRD, and both perform better than Cockcroft and Gold in estimating the actual kidney function. So why not use the equation that predicts the kidney function in the best way? The official watersheds, 30 milliliter, 60 milliliter, they are artificial anyway. So I would be inclined to use the CKD EPI.
To defend the honor of the cardiologists, there has been one survey among European cardiologists and nephrologists asking them whether they preferred the one or the other equations. Actually, cardiologists were better than nephrologists in that survey, and they used the creatinine clearance more often. But I think your answer is a very practical approach. So my last question, there are still some people, at least again here in Germany, who like to give dialysis patients heparin on a dialysis day, surely, and then to have them inject another dose of heparin, in most cases low molecular weight heparin, on the non-dialysis day. There's, to my best understanding, no data on this. Would you recommend to do so, or should we, if we go for anticoagulation, really stay with the DOACs and not do heparinization on non-dialysis days?
So as you say, there's even less data on the efficacy and safety of the use of low molecular weight heparins with the intention of stroke prevention, because that is what they are doing. And we know that as DOACs, they accumulate to various degrees in renal failure. So there's also the issue of dose adjustment, potential underdosage, potential overdosage. Of course, you can measure the anti-10A activity, but first of all, this is expensive. And secondly, I wouldn't know how to interpret the data because you have a prolonged elimination. So the shape of the area under the curve has changed. So if you measure a trough level and a peak level, it doesn't give you the sufficient data to judge whether you are over or under anticoagulating the patient. What you really need is an area under the curve. And that, of course, is not feasible in clinical practice. I believe that nephrologists might use this approach because we feel comfortable with low molecular weight heparins because we use them every day. But this doesn't mean that it's a good approach. And finally, long-term subcutaneous administration, it is very uncomfortable to patients. So I would certainly not recommend that approach.
Can I also ask one more add-on question that actually is pretty much in sync with a previous one on reducing or withholding the NOAC dose on the dialysis day? Have you tried it the other way around, that you reduced or even omitted the low molecular weight heparin with dialysis?
That's an excellent idea. And to my knowledge, it has not been studied. We have played with the idea to study that, but we lack the time to study. But it's an excellent idea.
So thanks a lot, Anne. This was a fantastic hour of discussion on anticoagulation. And we're so happy that you provided us with data in this field, because at least in our hospital, I can now clearly state that we shall no longer use any warfarin on Germany, Finprocommon, because your data strongly suggest against its use. You will join global leaders in nephrology some days after streaming this interview. We wish you a very, very successful meeting, and thanks for all your work you did in the last years, and we're looking forward to reading much more of your work in the next years. Thanks, Anne.
Thank you very much. It was very pleasurable.